My name is Ian Ware. I'm the program director for the Sleep Fellowship at Norwalk Hospital. Happy to join today. Just a few announcements. Please make sure that you are muted. Also, please see the instructions to receive CME credit for attendance. If you haven't signed up for the Yale CME profile, please do that so you can get CME credit. And then if you think anyone would enjoy viewing these lectures, may be interested in that, please send an email to yalesleepmedicine.grandrounds@yale.edu. And I'll be monitoring the session. So please, if you have any questions, you can use the chat. And at the end, we'll also open up, unmute anyone if anybody wants to ask any questions. These sessions are recorded and will be posted on the YouTube channel a few weeks after the presentation. So with that, I have the privilege of introducing our second wonderful fellow. You guys heard from Peter, and now this is Dr. Mansi Bhatt's opportunity. So she started out at Stony Brook for undergraduate and went to St. George's for medical school and came back to amazing Long Island in Stony Brook in Southampton for family medicine residency. And we were really fortunate to have her join our sleep fellowship program. And I will tell you, Mansi is obviously very smart and dedicated and hardworking, but she comes to work with a big smile every day, such amazing energy, really just lifts everyone up, so friendly. Patients love her. They love joking around with her. They have a good time. And she's going to be an amazing board certified sleep doctor soon. She has taken a position in 100% sleep medicine in New Jersey. So the field of sleep medicine is really lucky to have her as a clinician, and we're very proud that we were able to train her. So with that, I'd like to introduce Dr. Bhatt, who's going to be talking about wearable sleep technology with a focus on how you as the clinician can use this potentially in your clinical practice. Take it away, Dr. Bhatt.
Great. Thank you so much, Dr. Weir. That was very, very kind of you. Thank you for having me as a fellow. Hi, everyone. My name is Mansi. I'm one of the sleep medicine fellows here at Norwalk Hospital. And today I'm going to be talking to you about wearable sleep technology. We're going to be focusing on clinical insights on these consumer health trackers and how we can best use them in practice. And then before we begin, I don't have any disclosures. And then this is our CME slide, and I understand that this will also be posted in the group chat multiple times throughout the presentation. So what are our learning objectives for today? The presentation is going to explore wearable sleep technology, their growing role in sleep medicine, and how they're changing the way that we approach and manage sleep disorders. So we're going to be doing an overview of consumer health trackers, how they work, the data that they collect, clinical applications and benefits, identifying appropriate uses, and then, understanding some of their limitations and challenges along with a data review. So I'm going to start off with a case that may feel increasingly familiar in clinic. The topic of today's presentation isn't a rare or a hypothetical scenario. It's a new type of referral pattern in sleep medicine, aka I came in because something told me to come in. It's usually going to be some form of sleep tracker. So we have a 40-year-old male with a history of anxiety and hyperlipidemia, presenting with ongoing complaints of insomnia, daytime fatigue, and over the past 2 years, he's already undergone 3 PSGs. All were essentially negative, no clinically significant sleep apnea, no major abnormalities, and from a traditional sleep medicine perspective, you may feel reasonably assured at this point. You have 3 negative studies that you've looked at. But the patient is coming into the clinic now very anxious. He's bringing several printed reports generated after uploading his sleep data from his Apple Watch into multiple AI tools. And then the AI is basically flagging things like an irregular sleep architecture, REM fragmentation, low sleep efficiency. Importantly, the patient's anxiety is now escalating the more he reviews these reports, and he's interpreting the repeated algorithmic flags as evidence that something serious is being missed. And despite 3 negative sleep studies, he is now convinced that there must be some form of an underlying sleep disorder going on. He's requesting yet another PSG. And then this case overall illustrates a growing phenomenon that's happening at the intersection of consumer health technology, wearable devices, and then the use of AI in generating a form of an interpretation. Patients are now arriving not just with symptoms, but with months of personal biometric data and algorithmic interpretations of that data. So these tools can be empowering, but they can also amplify uncertainty, misinterpretation, and then cause further anxiety. So how do we go about managing this? We have to first understand why sleep measurement matters, not only to us, but to patients as well. It raises several important questions for clinicians, as in what exactly are these devices measuring? How accurate are consumer sleep trackers? And most importantly, how should we be integrating them or contextualizing this information when patients present it to us in clinic? And to answer that, we have to first understand that the rapidly expanding ecosystem of consumer sleep tracking technologies is booming. It's so popular now. We know that sleep measurement matters. It has broad systemic effects. It's going to be influencing cardiovascular health, metabolic regulation, mental health, cognitive performance, and even mortality. We also know that short sleep duration, particularly less than 6 hours per night, is associated with increased cardiovascular risk, impaired glucose metabolism, and a higher all-cause mortality. So it's not surprising that patients are now increasingly motivated to track their sleep. And sleep disorders are very common. About 20 to 30% of individuals experience some form of sleep disturbance. If we look at specific conditions, insomnia affects about 10 to 30% of individuals. OSA is estimated between 9 to 38%, depending on the population that's studied. And then circadian rhythm disorders and RLS symptoms, they're also fairly common, affecting roughly between 7 to 16% and then 3 to 12% of the population, respectively. And importantly, these conditions are not evenly distributed across populations. Prevalence rises with age. More than half the adults over the age of 65 report chronic sleep complaints. There are also clear sex differences. Women have higher rates of insomnia and RLS, while men tend to have higher rates of sleep apnea. But that gap does narrow after menopause. And then lastly, socioeconomic factors also do play a role. There's a higher rate of sleep disorders in populations with a lower income or educational attainment. So we also have to look at the health and economic impact as well. There's a bidirectional relationship with mental health. 40 to 50% of individuals with insomnia also have a coexisting psychiatric disorder. And then they're also linked to cardiovascular disease, obesity, type 2 diabetes. And sleepiness contributes to about 10 to 15% of fatal motor vehicle accidents overall. And in the US, sleep disorders and sleep deprivation are estimated to cost over $411 billion annually due to healthcare expenses and lost productivity. The broader cultural context around sleep is also changing. The global sleep economy is now over $500 billion worldwide. There's a massive consumer interest in sleep optimization. You see the rise of trends like biohacking, sleep maxing, where individuals are actively trying to engineer better sleep using technology, supplements, behavioral strategies. And at the same time, there's been a cultural shift away from the I'll sleep when I'm dead hustle mentality. Now we're viewing sleep more as a critical component of performance, of health, and longevity. And in many ways, being well rested is even something of a status symbol now. It's associated with productivity, mental clarity, emotional resilience. And this helps explain why so many people are now investing heavily in tools to measure and optimize their sleep. So what is sleep technology? Wearable sleep technology includes any device that's worn on the body that tracks sleep patterns, monitors physiological parameters, and then provides feedback on sleep quality. These are going to be devices that are available over the counter. They don't need a prescription or any sort of clinical recommendation. And many of these were originally designed as fitness trackers. The devices now claim to measure several different biosignals, which we'll go into, but heart rate variability, skin conductance, and temperature are some to name a few, in addition to motion, from which information about behaviors, including sleep, will be extracted. Their accessibility is primarily through some form of a cloud-based platform that's used for data storage and integration, usability, and then novelty and affordability has also led to their widespread use and contributed to an increasing awareness about the importance of sleep in the general population. Some well-known examples of wearable devices, fitness trackers, including the Fitbit and the Whoop strap, smartwatches like the Apple Watch and the Garmin watch, and then there's certain like sleep-specific wearables like the Oura Ring and the Dream headband. Traditionally, sleep diagnosis relies primarily on PSGs. That's our clinical gold standard, but they do have some well-known limitations. It's expensive, it's technically complex, it technically only captures one night of data, and it occurs in a lab environment that's probably not reflective of a patient's typical sleep environment. And in contrast, these wearable sleep technologies collect data continuously in real-world settings, and they sync with companion apps that analyze sleep patterns. They estimate stages of sleep. They give users feedback and recommendations, mostly in real time. And this type of convenience is what has led to its rapid adoption. About 35% of Americans have used some form of an electronic sleep tracking device, and most users find them very helpful. Some have even changed their behavior based on the feedback that they have received. And because they're relatively inexpensive, they are capable of capturing long-term sleeping patterns. The devices have rapidly expanded not only in consumer wellness, but also in certain research settings. So consumer sleep trackers have become a major segment of digital health. 1 billion devices are expected to be in use globally by the 2020s, and sleep tracking is one of the most commonly used features in these smartwatches and rings. The global sleep tracking device market is estimated at about $26.6 billion in 2023, and it's projected to reach over $58 billion annually by 2030. CSTs are exploding in popularity, but there's no clear definitive clinical guidance on their use. The wearable CHTs entered the market around 2011. There was Jawbone, Fitbit, and Garmin being the early pioneers. The first two, Jawbone and Fitbit specifically, did include sleep tracking capabilities shortly after launch, and thus they're most widely credited as being the first consumer sleep trackers using motion and heart rate signals for sleep detection. And the rapid technological development of CHTs is targeted towards fulfilling mostly consumer needs and manufacturer business objectives. They may differ from medical and research goals. There's a growing personal adoption of health trackers. It has tremendous potential to benefit human health and well-being. It affords a more granular and comprehensive approach to sleep over a longer period of time than is traditionally used with maybe like an actigraphy device. And although the awareness of sleep being a multi-dimensional issue is acknowledged, the norms for sleep regularity, its efficiency, its continuity across the lifespan, and in different cultures does remain to be established. So how do we navigate this black box of sleep wearables, right? Clinicians are increasingly seeing patient-generated sleep data, but the reliability and the interpretation does vary. Patients themselves are going to increasingly present clinicians with wearable sleep data. And then the challenges will include unknown accuracy, proprietary algorithms, and then a lack of clinical guidelines. Within the last few years, there have been several reviews and position papers that have addressed the promises and the pitfalls of using CHTs in clinical or research settings, and they have provided guidance on standardizing sleep measurements and their evaluation. In 2018, the American Academy of Sleep Medicine published their official position statement on consumer sleep technologies. Sleep clinicians were encouraged to be familiar with CSTs, mostly because patients are increasingly bringing in their own data into appointments. But clinicians do have to be aware of their limitations. For example, these devices are going to be estimating sleep based off movement and heart rate that doesn't necessarily measure brain activity like a PSG does. But the devices can help people track patterns over time, increase awareness of sleep habits, and then sometimes motivate healthy behavioral changes. They can help identify patterns that could warrant further clinical evaluation. And then in 2025, the World Sleep Society Task Force created consensus recommendations for the use of CHTs that monitor sleep. The goal was to provide practical guidance for clinicians, clarify appropriate versus inappropriate uses, taking a look at the limitations of the current technology, and then to help guide future research and device development. The main points from that paper is that wearables can be helpful in evaluating sleep patterns and in screening for possible disorders like sleep apnea, but the results should always be confirmed with clinical testing, for example, a PSG, when you have to make a diagnostic decision. And most CHT's algorithms are proprietary, so clinicians should be interpreting them with caution. And then the best practices are listed for different users. So for consumers, they should be using wearable data to understand and track personal sleep behaviors, not to use them to self-diagnose medical conditions. And then clinicians should be using wearable data as complementary information, mostly for long-term sleep patterns. And they should be relying primarily on clinical tools in order to make a formal diagnosis. Researchers should be using these devices to design performance evaluation studies using transparent methods and consistent benchmarks across different devices. And then manufacturers should be collaborating with clinicians to improve accuracy, transparency, usability, and then work towards clinical certification where appropriate. So we'll do a quick overview of CHTs and the technology behind them. First is accelerometry, or some form of an actigraphy collecting device. So the mechanism is going to be using movement thresholds to infer sleep and wake cycles, sleep onset latency, and then the total sleep time. The clinical caveat to this is that there's a high sensitivity for sleep detection, but a low specificity. So quiet wakefulness, aka in insomnia patients, it's going to be frequently misclassified as sleep. And you'll see this further on in the presentation as well as we get into the data review. There's also a mobility bias. So accuracy depends on normal limb mobility. Performance is degraded in populations who have motor disorders or restricted movement. So there is a bit of a normalcy assumption. We need to understand that these algorithms are mainly trained on healthy cohorts. So when you apply them to patients who have OSA, RLS, some form of an autonomic dysfunction, the biomarkers that the device is going to look for is often absent or distorted. Then we have the PPG. So this is going to optically estimate heart rate and heart rate variability as proxies for autonomic nervous system shifts during sleep staging. And then the clinical caveat to this is that it's highly susceptible to motion artifacts and peripheral perfusion issues. So signals might be unreliable in patients who have dysautonomia, arrhythmias, or those on medications that affect heart rate or perfusion. So while the PPG might be very good during sleep because the patient is actually lying still, the moment that they awaken or they move, which is often the data that we care most about, the signal to noise ratio may collapse, so you might get inaccurate data. Then we have thermometry and electrodermal activity. So this is going to track the rise in distal skin temperature and the subsequent core body temperature drop that's associated with sleep onset. There's also a sweat response that's going to be measuring conductance changes in the skin, typically peaking during slow wave sleep for thermoregulation, and then ceasing during REM. And the data limitation to this is that most devices are going to report relative trends rather than absolute values, which complicates cross-patient comparisons. So, while these sensors are medical grade, the logic that combines them, even across different devices, it remains unknown. So how are we going to compare these CHTs to our gold standard PSG? Non-EEG wearables measure movement and autonomic signals that are modulated by sleep. They don't measure electrical signals that are related to brain activity, which is what most of our current knowledge about sleep is based off of. And we do have to emphasize to patients that while these sensors, there is a lot of integration between all the data that they collect, but they're still not in the end measuring brain activity. So let's take a look at the accuracy of the consumer sleep trackers. The main diagnostic challenge that remains is that whether or not the CSTs can mirror or fail to mirror a PSG. And while the CHTs do show high sensitivity in correctly identifying sleep, they do suffer from low specificity, aka they can frequently misidentify quiet wakefulness as sleep. The CHT doesn't know when a patient decides to sleep. They essentially only know when a patient stops moving. And there can be fundamental measure discrepancies between the device and what the patient thinks is happening. So for example, for bedtime versus intent, the CST is going to lack the nuance to distinguish between time in bed versus the actual sleep period, which is the intent to sleep, which may be much shorter than the time spent in bed. And then the quiet activity artifact. So real world pre-sleep behaviors like reading, meditation, using a smartphone, scrolling on an iPad, they involve minimal movement, so these devices may trigger a false sleep onset. And then systemic overestimation. Because the wakefulness is underdetected, most CHTs will systematically overestimate the total sleep time and sleep efficiency. Patients might become frustrated with this in particular. Their subjective experience may report lying awake for hours in bed, but the device is going to report that they were asleep the whole time. So what are the clinical implications for specific populations? In patients who have insomnia, aka in patients who have a high wake after sleep onset or some form of sleep initiation difficulties, the CHT data is going to be least reliable. And then device heterogeneity. Clinicians do have to take into account that there's significant variance in bedtime detection across algorithms, across different manufacturers, a Fitbit versus an Oura Ring versus a Garmin. So a patient that switches from a Garmin watch, for example, to an Apple Watch might see an improved sleep score just due to the change in the algorithm, aka what the manufacturer has determined as their movement threshold, not necessarily due to a change in their physiology. And then naps. So naps are periods of sleep outside of the main, usually nocturnal sleep period. How are CSTs accounting for this? They're increasingly integrated as features in wearable devices, but accurately detecting them and then distinguishing them from quiet wakefulness after physical activity is still a technological challenge. Some manufacturers do allow users to manually edit the sleep periods that have been identified as naps. They usually do have to go back and then change these time periods. But there are certain devices that have an automatic nap detection feature that they integrate. Currently, the Garmin watch has the shortest nap detection feature. It takes about a minute for the device to pick up if a patient is napping. Now we get to the sleep score. So these are proprietary measures that provide some form of an overall grading of a night of sleep in a single number. It's usually out of 100. These are non-standardized measurements. They often use the same variables, some form of sleep typing, timing, duration, continuity, and efficiency. And while the absolute scores may not currently be comparable across manufacturers, they do represent a gross oversimplification of the nature of sleep. They are more likely to engage the user than a long list of sleep variables. So in addition to measuring sleep timing, duration, a lot of these devices also collect physiologic data. And one of the most commonly reported metrics is the resting heart rate, or the RHR. The resting heart rate is defined as the heart rate measured when a patient is at rest and not engaged in physical activity. And clinically, the RHR has long been used as a marker of overall cardiovascular health. There's a large body of epidemiological research that shows that a higher resting heart rate is associated with increased cardiovascular mortality. And for example, findings from the Cardia study demonstrated that longitudinal changes in resting heart rate also carry prognostic value. In that study, an increase in the resting heart rate of about 5 beats per minute or more over a 5-year period was associated with worse cardiac outcomes, including left ventricular dysfunction and heart failure. Because wearables can measure heart rate continuously and over a long period of time, they do provide an opportunity to monitor resting heart rate trends in everyday settings rather than relying solely on measurements obtained in clinic when you're getting vital signs. However, interpreting resting heart rate data from wearables does require some caution. So resting heart rate is not a static physiological parameter. It changes. It can fluctuate for many reasons, including illness, psychological stress, alcohol intake, and then medication effects. Circadian rhythms also influence heart rate, meaning that values, they may vary depending on the time of day that they were measured. And in addition, there is substantial variability between individuals. So what's considered a normal resting heart rate in one person might be different for another. And then this may vary across the device that's collecting the data as well. And for these reasons, the most useful way to interpret the wearable-derived resting heart rate device in clinic is not necessarily by focusing on a single value, but rather by examining the patterns and the trends over time within the same individual. So changes from a patient's baseline may be more clinically meaningful than comparisons across different individuals. So far, we've been talking about resting heart rate. We've been talking about the data and the technology behind the wearables. But modern devices are also looking at much more. And they're using this data that's being collected to provide a deeper insight into autonomic physiology. And two of the most commonly reported metrics are heart rate variability, or HRV, and then peripheral blood oxygen saturation, often labeled as SpO2 in these devices. The measurements are attractive because they potentially reflect physiologic stress, recovery, autonomic balance. But just like the resting heart rate, they also do come with important measurement considerations and sources of variability that clinicians should be aware of. For example, for the HRV, for accurate measurements, the device does have to be worn snugly to the skin and in a manufacturer recommended orientation. And then for blood oxygen saturation, it can be influenced by factors like altitude, skin tone, peripheral perfusion, and then the placement of the device overall. This is the point that we're going to be moving from what these devices claim to measure, the data that they're collecting, to how accurate these measurements actually are. Most consumer sleep trackers rely on a combination of accelerometry and optical heart rate sensing using PPG. And then some of the newer devices are also going to be looking at things like skin temperature, oxygen saturation. The signals are then fed into some form of an algorithm that's going to estimate sleep versus wake, and then also sleep stages. So from a clinical perspective, the key question from this isn't just what signals is the device collecting, but how well do the derived sleep metrics compare to our gold standard sleep measurements? And in the sleep field, our reference standard is always going to be the PSG. It integrates EEG, EOG, EMG, respiratory signals, and other physiologic channels to determine sleep and then to determine its staging. And so the validation studies that we're going to look at are typically going to compare the consumer devices to a PSG or to PSG and actigraphy. And it's going to look at metrics like total sleep time, sleep efficiency, wake after sleep onset, and then the accuracy of sleep staging. So with that framework in mind, let's look at some of the published validation literature studies across different consumer devices. So in 2024, we had a study published in Sleep Review magazine that looked at 35 healthy adults without sleep disorders to evaluate how accurately three popular consumer wearables, the Oura Ring, the Apple Watch, and the Fitbit, tracked sleep compared to the PSG, which is the clinical gold standard. So this is a key study that compared these three proprietary algorithms directly against the PSG. And the main focus was on binary sleep detection, sleep versus wake, a four-stage sleep classification, wake, light, deep, and REM, and then agreement with PSG staging and then duration estimates. Overall, consumer wearables perform quite well, even at the most basic task of distinguishing sleep versus wake, with most devices demonstrating greater than 95% sensitivity for detecting sleep. But this is partly because patients should be spending the majority of the night asleep, which makes that metric a lot easier for these devices to achieve. And where these devices accurately differentiating the various stages of sleep. And among the devices studied, the Oura Ring showed the closest alignment with the PSG and had the highest stage classification accuracy and sensitivity and a four-stage breakdown that didn't significantly deviate from the PSG benchmarks. Devices like the Apple Watch and the Fitbit can still be useful in generating like general sleep insights and maybe looking at trends over time, but they tend to misestimate the duration of specific sleep stages when compared with the PSG. So sleep staging is moderate at best overall amongst all these devices. These devices are going to frequently overestimate light sleep and then underestimate deep sleep. The Oura Ring once again comes in first between 76 to 79% of sleep stage sensitivity, with the Apple Watch coming in last at around 50 to 86%. Higher sensitivity means that the device is more often correctly identifying the true sleep stage as recorded by the PSG. And we do see a significant drop-off in performance for slow wave sleep or N3 detection. The Oura Ring leads once again almost at about 80%, while the Apple Watch Series 8 only caught about half of the deep sleep epochs at about 50.5%. And this is a critical point when patients come to you in clinic worried about the lack of deep sleep on their watch. It's going to be a device sensitivity issue rather than a physiological one. And then regarding the four-stage sleep classification, aka, how likely are these devices to match up directly to what the PSG is determining in figuring out different sleep stages? So the Oura Ring once again did the best overall. The unit of measurement used was a Cohen's kappa. So this is a statistic measurement that measures the agreement between two different systems. Values closer to one mean a stronger agreement. So the Oura Ring had a Cohen's kappa of about 0.65, and then the Fitbit came in last at about 0.55. So overall, this study does indicate that the Oura Ring came in closest to matching the duration profile scored by human technicians in comparison to the PSG. But when we move beyond just simply determining whether a patient is asleep and then start looking at the different sleep architecture, the differences between the devices do become more apparent. Most devices perform reasonably well when estimating total sleep time, but when researchers compared the stage-specific sleep durations with the PSGs, there were some biases that came about. For example, the Apple Watch, it tended to substantially overestimate both light sleep and deep sleep. And in this study, the light sleep was overestimated by the Apple Watch by approximately 45 minutes, and deep sleep by about 43 minutes when compared to the PSG. The Fitbit Sense 2 also demonstrated some biases in sleep estimation, particularly for light and deep sleep. However, the magnitude of this difference was generally smaller than what was observed with the Apple Watch. And interestingly enough, the Oura Ring didn't perform similar to these two devices. It was kind of on its own. It didn't show any significant systematic overestimation or underestimation of major sleep stages. And overall, I think this highlights a very important point that even when devices appear similar in their consumer-facing outputs, aka what data they're giving patients, the underlying algorithm and the performance characteristics can vary substantially. I will also say that cost does play a role in this. The Oura Ring is generally on the higher end of device costs. I think starting out it's about like $350. And then you do need to have a monthly subscription service in order to fully get all of the features that it's collecting, all the data that it's putting together. So that does play a role in which consumer will be able to afford this device versus not. We had a study published in 2020. This is one of the most comprehensive head-to-head validation studies of consumer sleep technologies. The investigators were comparing 7 different consumer devices that represented 3 main technology categories. So we had wrist wearables using accelerometry and PPG, contactless bedside sensors using sonar or radar, and then under mattress sensors measuring movement and respiration. So all participants underwent simultaneous PSGs, that's our gold standard. And the key finding is that nearly all devices, once again, they detected sleep very well. The sensitivity was over 90%. But wake detection remained poor. This is a well-known limitation of actigraphy-based systems. So sleep staging algorithms performed inconsistently overall. And this is important as it highlights that consumer stage estimates should be interpreted with caution. And from a clinical perspective, this does support the idea that these consumer trackers can approximate total sleep time. They may tell you, well, a patient slept for this period of time quite well, but they can't replace a PSG for diagnostic purposes. And then we had a study published in 2024, and this is very important as it directly compared consumer trackers with both PSGs and actigraphy. All of the devices tested were wrist-based wearables. They relied primarily on accelerometry. And then there was some incorporation of heart rate data as well. And the most consistent finding was that the total sleep time estimates were reasonably accurate. They were typically within the same error range seen with actigraphy. But once again, the devices struggled to detect wakefulness, particularly the brief awakenings that occur during the night. And another important observation to keep in mind is that sleep staging algorithms vary dramatically across manufacturers because each company is using a proprietary algorithm that's not necessarily the same. It may incorporate some of the same variables, but the algorithm in the end is going to be different. And the key takeaway for clinicians is that consumer devices may approximate actigraphy, but the stage data should not be interpreted as being equivalent to PSG staging. And then we had a study published in 2020, which evaluated a consumer accelerometry-based device against PSG in 41 sleep clinic patients. And in the testing cohort, the wearable demonstrated an overall accuracy of about 90% for epoch by epoch sleep-wake classification. The device showed very high sensitivity for detecting sleep at about 95.5%, which is consistent with what we see across most wearable devices. However, wake specificity was much lower at about 55.6%, which means that the device is going to frequently misclassify quiet wakefulness as sleep. And importantly, these results are similar to research-grade actigraphy devices. which had about an 88.7% accuracy, a 92.6% sleep sensitivity, and a roughly 60% wake specificity. And then the main take-home point from this is that consumer wearables can perform reasonably well for identifying sleep versus wake in certain situations. But then, like actigraphy, they're going to struggle to detect wakefulness when the patient is lying still or motionless in bed. And then in 2019, we had a study published focusing on adolescents. And this is really important because adolescents are one of the largest users of consumer sleep trackers, but there's relatively few validation studies that exist in this population. The investigators compared the Fitbit wearable device with both PSG and actigraphy. Participants underwent experimental sleep manipulation, including sleep restriction protocols, which essentially allowed the researchers to test the performance of these devices across different sleep conditions. And the device performed relatively well for sleep duration estimates, again, showing a performance that was comparable to the actigraphy. However, the device systematically underestimated deep sleep, which is a common finding in wearable sleep trackers. And this occurs, again, mainly because these algorithms are attempting to infer sleep stages using movement and heart rate variability rather than EEG. So while these stage trends might be informative, the stage-specific values shouldn't be interpreted clinically. And then in 2020, we had a meta-analysis published that provided the overall high-level, like best evidence summary of the current research that was out there for consumer sleep tracking technologies. A total of 26 studies were used, and the authors evaluated multiple categories of devices, including wrist wearables, smart rings, under mattress sensors, contactless bedside radar or sonar sensors. And the overall conclusion is that these devices generally perform similar to actigraphy for estimating sleep duration and maybe even sleep efficiency. However, the accuracy is much more variable in patients who have some form of an underlying sleep disorder. Something like insomnia or sleep apnea. And then another important issue highlighted is that the algorithm is not transparent. We don't know the specifics of each algorithm across different manufacturers, across different devices. So it's difficult for clinicians to interpret these values or validate sleep staging outputs. And it's also why these consumer sleep trackers should be viewed as behavioral monitoring tools in clinic rather than a diagnostic device. So up until this point, we've been mostly discussing these consumer sleep trackers broadly. We took a look at some studies evaluating their measurement accuracy against PSGs. And for the next portion of the talk, I do want to narrow the focus specifically to insomnia and sleep apnea. We'll talk about insomnia first. And the reason for this is kind of where the devices are increasingly intersecting with clinical sleep medicine. So insomnia is one of the most common sleep disorders we encounter in practice. It's also the condition where patients are more likely to be actively engaging with their sleep data from some form of a consumer device. And then many patients with insomnia are already coming into the clinic with months of nightly sleep metrics from devices like their watches, their rings, phone apps. And the trackers are giving them estimates of total sleep time, sleep efficiency, sleep staging, night-to-night variability, which on surface seems very appealing for a disorder that's often characterized by chronic patterns over time. But at the same time, insomnia is fundamentally a disorder of sleep state perception and sleep-related cognition, which means that if you're going to be introducing large amounts of sleep data into the patient experience, that can have a lot of complex consequences and effects. So the key question for clinicians becomes, when do these sleep trackers actually help us understand or manage insomnia? So CHTs can provide informative or objective data to support clinical management, possibly replacing research actigraphy devices that have been used for decades and using them in combination with sleep diaries. Sleep tracking can assist in engaging and motivating patients to adhere to sleep treatment, and some devices are also useful for treatment administration. In 2017, there was a small study published of about 19 adults with chronic insomnia. The average age was about 45 and average insomnia duration of about 5 years, who combined consumer health trackers with CBTI, and it did show promising results. Those using the trackers demonstrated a higher adherence to the intervention, likely due to increased engagement with the app, feedback from the device, and sleep efficiency improved roughly 12 to 26%, depending on how it was measured. And about 95% of participants reported that the mobile application helped in managing their insomnia. overall, this suggests that combining the sleep trackers with some form of behavioral therapy may not only support adherence, but also enhance clinical outcomes in insomnia management. And then in 2017, we had another study published. This was one of the earliest ones that evaluated consumer sleep trackers, specifically in the insomnia population. The participants wore a Fitbit Flex. It's a wrist-based sleep device, while also undergoing overnight PSG. The results showed excellent correlation for total sleep time, but the device systematically overestimated sleep in insomnia patients. And this occurs mainly because the actigraphy-based devices are going to classify motionless wakefulness as sleep, which is extremely common in insomnia. And consequently, while good sleepers showed 82% agreement with the PSG, the agreement dropped to about 39% in insomnia patients. And the clinical implication for this is that consumer trackers may underestimate insomnia severity, particularly wake after sleep onset and then sleep latency as well. And then in 2020, we had a study published that tested consumer trackers in clinical insomnia populations only rather than healthy sleepers. The participants wore a Fitbit Alta HR that combines accelerometry with heart rate sensing. And then the variables looked at were total sleep time, sleep efficiency, sleep latency, and then wake after sleep onset. The sleep detection sensitivity was very high, almost 97%, which means that the device very rarely missed sleep, but the wake detection specificity was very poor, around 38%, meaning that many wake periods were actually misclassified as sleep. And this is really problematic in insomnia, where patients are going to often lie in bed motionless but awake. The result is a systematic overestimation of sleep quality, but interestingly enough, the Fitbit's performance was statistically similar to research actigraphy, which does suggest that the consumer sleep trackers may approximate actigraphy, but they still do share some of the same limitations. And then in 2020, we had a study that was published that used a Garmin Vivo Smart HR smartwatch in a randomized controlled trial of suvorexant for insomnia in Alzheimer's disease patients. Participants underwent lab PSGs, but also wore the wearable continuously. I thought this was really interesting, as this was one of the only devices out there that tested these sleep trackers in a patient population that is often very hard to bring into the clinic or bring into the sleep lab in order to get a sleep study. Alzheimer's disease is very complex, and oftentimes you will see patients or their family members attempting to use these sleep trackers or these fitness devices to help further enhance their current management of the disease. And the key finding was that the wearable detected the same direction of treatment effect as PSG, specifically an increase in the total sleep time of about 28 minutes. And this suggests that consumer trackers can be used for longitudinal monitoring in clinical trials, particularly when the PSG is impractical to obtain. But the device is still not accurate enough for detailed sleep architecture analysis. So consumer sleep trackers are most effective when they're paired with behavioral support, such as coaching, CBT-style interventions. There were two recent randomized trials, the Stitch and the Sleep Opt, that used trackers alongside structured education and coaching specifically designed to extend sleep rather than to just monitor it. The programs achieved a high adherence and retention rate, about 86 to 89%, which does suggest that these participants were engaged, they were motivated. And then the feedback from the trackers did help patients recognize when they were not getting enough sleep, to help set specific sleep extension goals, and then to stay motivated to meet them as they would be getting the feedback in real time on their app. So while these studies primarily focus on feasibility and engagement, they do highlight that trackers can actively support behavioral change when it's embedded within a structural sleep program. The clinical take-home point from this is going to be that devices are most useful as a feedback tool within some form of a behavioral framework, rather than as a standalone treatment for insomnia or sleep extension. Sleep duration, the main question that we want to look at for this is that can CHTs help with sleep extension? And this study describes the development of a technology-assisted behavioral sleep extension intervention. It was called the Sleep Bunny mobile app. And the goal of this app was to address the public health problem of short sleep duration. This affects about 30% of adults sleeping less than 6 hours per night. And the intervention looked at three main components. There was a mobile app, the Sleep Bunny app, that delivered behavioral lessons and sleep tools. There was a wearable sleep tracker. Specifically in this study, they used the Fitbit Flex. And then there were weekly telephone coaching sessions that were designed to reinforce the behavioral goals that were set forth. And the theoretical framework, it was based mostly on motivational interviewing, cognitive behavioral strategies, along with the supportive accountability model, with the data that they were being told based off the app. This does propose the idea that individuals are more likely to adhere to behavioral interventions if they're monitored not only by like some form of a human coach, but also if they're getting feedback in real time from the device. So the intervention lasted about 4 weeks. They included weekly coaching sessions. The sleep was monitored using actigraphy, and then the daytime sleepiness was measured using the Epworth scale. The results did show substantial improvements in sleep duration. Participants, one, increased sleep from about 5.75 to 7.35 hours per night, and participant two increased their sleep time from 4.3 to 6 hours. And daytime sleepiness improved significantly as well. The Epworth dropped from 7 to 0 in participant 1, and then from 18 to 9 in participant 2. So sleep architecture metrics like wake after sleep onset, sleep efficiency did show some mixed changes, but this was primarily a sleep extension intervention rather than an insomnia treatment. And the participants reported that the wearable sleep tracker was the most engaging part of this intervention, which does suggest that if you integrate these consumer sleep trackers in clinic with some form of a behavioral intervention, you're more likely to have increased adherence, increased retention. And then the authors overall concluded that the Sleep Bunny intervention did show initial feasibility, but larger clinical trials are needed to determine the effectiveness. The next section of the talk does shift to a different clinical question, whether these devices have a role in screening for sleep apnea. So OSA is both highly prevalent and substantially underdiagnosed. It does make that field an attractive target for these scalable, widespread screening approaches with these devices. And at the same time, these consumer wearables are collecting physiologic signals that are potentially relevant to breathing disturbances, abnormal motion during sleep. So many modern devices are now incorporating PPG-derived heart rate data, heart rate variability, and then in some cases also incorporating peripheral oxygen saturation measurements. These devices will also attempt to infer respiratory patterns, or detect some form of an abnormal physiologic variability that's associated with apneic events. Because these devices are worn nightly over long periods, they do raise the possibility of passive identification of individuals who may be at risk for sleep apnea, potentially prompting some form of a formal evaluation later on. But it is important to emphasize that the consumer health trackers do not diagnose sleep apnea, which is sometimes a misunderstanding that patients tend to have. They think that if they get some form of an alert on their device that tells them they have sleep apnea, that's a definitive diagnosis. That's not true. The diagnostic standard remains PSG or some form of a home sleep apnea testing device. So the question the literature is addressing is narrower, like can these devices meaningfully identify individuals who then may warrant further intervention in a sleep clinic? So sensors embedded in these trackers will be collecting data that can help detect sleep apnea, but because these algorithms that are used are proprietary, the specific inputs that are used by these devices are uncertain. And then many of these devices are going to feature some form of a pulse ox, which is going to enable the detection of episodic oxygen desaturation in conjunction with abnormal wrist motion. And there are 2 devices out there currently that have received FDA clearance to detect individuals at risk for undiagnosed moderate to severe obstructive sleep apnea. And this happened mostly in 2024. It was a big year for sleep apnea screening devices. We have the Samsung Galaxy Watch and then the Apple Watch that have been cleared. As there is significant night-to-night variability in apnea severity, the CHTs could provide a better indication of disease severity than like a single night PSG would. The goal is to use it as a tool to identify patients that have sleep disordered breathing, which would then warrant prompt evaluation by a sleep medicine specialist. And as of this time, there's no CHT device that's FDA cleared for the diagnosis or longitudinal monitoring of OSA. This study looked at whether the PPG signals from a wrist wearable watch could detect sleep apnea. And the overall rationale for this is that OSA causes repetitive cycles of hypoxia and arousal, which then should lead to cyclical variations in the heart rate. So the algorithm should be able to detect this pattern in some form of a pulse waveform. And then participants in this study also underwent a simultaneous PSG to compare. And the study found a strong correlation between the wearable signal and then the AHI. It was an R of about 0.1. The wearable algorithm achieved an AUC of about 0.88 for detecting moderate to severe sleep apnea, with the sensitivity around 82 to 85% and the specificity around 80%. And then the key take-home point from this is that cardiac signals alone may allow some form of a passive sleep apnea screening using widely available consumer devices. But the authors do emphasize that this method is best suited for screening and risk stratification, not for diagnosis. There was a newer study published in February of 2025 that evaluated whether smartwatch motion sensors alone could detect sleep apnea. The device used was an Apple Watch. It relied entirely on inertial measurement units, which included an accelerometer and a gyroscope. And then the sensors captured subtle movements from respiration, cardiac vibration, body movement during sleep. And the investigators looked at over 52,000 30-second sleep epochs. About 24% of them contained apnea or hypopnea events. And then several machine learning models were also tested. The one that performed the best was the random forest. The algorithm achieved an AUC of about 0.83, which would indicate some good discrimination between apnea and normal breathing. And importantly, when classifying patients by disease severity, the algorithm detected moderate to severe sleep apnea with 100% sensitivity and 90% specificity. For severe OSA, it was even higher with 100% sensitivity and specificity. The estimated apnea severity index did strongly correlate with the PSG-derived AHI, an R of about 0.93. And the take-home point from this study is to demonstrate that consumer smartwatches may eventually function as some form of a large-scale screening tool for sleep apnea, potentially identifying underdiagnosed patients earlier. And then the authors still do emphasize that a clinical diagnosis still requires a PSG or home sleep apnea testing. When integrating consumer health trackers into clinical practice, it is important to understand their limitations and appropriate use. For example, if a wearable flags sleep apnea, it's typically detecting some form of a motion-based pattern over multiple nights. It's not sensing airflow or oxygen changes or looking at brain waves. And this is something that patients should be then discussing with a clinician. It's not going to give some form of an AHI or confirm a diagnosis. And then in contrast, a sleep study is going to be looking at many different factors. A lot of different channels are used. And that's going to allow us to actually give a formal diagnosis regarding the type and the severity of the sleep apnea, which will then guide management decisions. Wearables can miss cases that a lab study would typically detect, or they could flag patterns that don't correspond to clinically significant AHI. So clinically, these devices should be used as screening or engagement tools, giving supplementary information rather than replacing diagnostic testing. And while there are limitations, the clinical integration of these CHTs is feasible. There was a 2024 study published that tested the real-time transmission of Apple Watch biometric data, heart rate variability, step count, activity directly into an EMR in a rat-on clinic. And the goal was to enable clinicians to review wearable collected data during routine follow-up visits. The results were encouraging. Data transmission was successful. It was reviewed by physicians about 95% of the time for patients, and trends in biometric data did provide meaningful insights over time. So the study does demonstrate that with the right systems in place, wearable data can be integrated into routine clinical workflows that allow for actionable information to support patient care. So just a quick overview of the overall benefits. So these sleep trackers are going to give personalized sleep insights. They're going to be very easy to use. They're non-invasive. There's no need for overnight visits to a sleep clinic. It's going to empower patients. It's going to give individuals more control over their sleep health. And it'll be integrated with other health data. Most of these devices are synced with a fitness tracker. They're going to be giving a holistic view of a patient's health, including exercise, recovery, stress management. And then regarding the limitations, so many wearables lack sufficient clinical validation for specific sleep disorders. They make them unreliable for a formal diagnosis. They're not approved for medical diagnosis or treatment, and patient expectations for data tracking may sometimes exceed what the technology can deliver. We do also have to keep in mind battery life and cost. So like mentioned before, so a lot of these devices do require a monthly subscription service in order to enable full use of all the features that they offer. And then longer use may require charging of the device, may lead to discomfort during sleep. And then we do have to take into account privacy concerns. So these devices are collecting sensitive data on sleep and health, and they could be vulnerable to data breaches if not properly protected. Regarding accuracy concerns, so while these CHTs are great for tracking trends, they're not going to be as accurate as clinical tools for PSGs or home sleep apnea tests. And many factors do affect the performance of the wearable. So skin perfusion can vary from person to person. Permanent or temporary changes to the skin, like tattoos, can also impact heart rate sensor performance and make it difficult to get a reliable reading. And then motion is another factor that can affect the heart rate sensor. So rhythmic movements like running or cycling are going to give better results compared to irregular movements like tennis or boxing. And then lastly, there will be an over-reliance on the data. So some users may become fixated on what their sleep device is showing, leading to anxiety or even a sleep tracking syndrome, aka obsessing over minute fluctuations in the sleep quality, which does, want me to go towards orthosomnia, which we will talk about. But in terms of how we should be using these devices in clinic, so we want to use them to support long-term monitoring. We want to focus on trends, not on single nights. The goal is to interpret the sleep stage data cautiously, and then we want to use these devices as a behavioral tool, not as a diagnostic device. So when you're advising patients on consumer sleep trackers, it's important to frame them as a tool for long-term self-monitoring rather than diagnostic devices. Encourage patients to focus on weekly averages, maybe even like a weekly trend, instead of single night fluctuations, to help them understand the difference between an acute sleep loss versus chronic insufficient sleep. And then the big take home point is this last bullet point here, how to integrate this thoughtfully into some form of a clinical discussion. So the device data should be used to motivate, educate, support adherence, but it should always, be confirmed, or diagnosis should be guided, and treatment decisions should be made using some form of a standard clinical method. When things like this aren't properly followed, patients do become very over-reliant on what their tracker is showing them, which can often worsen their sleep symptoms and then cause them to have orthosomnia. I would be remiss if I did a talk on sleep trackers and then didn't talk about orthosomnia. It's a relatively new clinical phenomenon. It was first introduced in 2017 by Dr. Kelly Glaser-Barron and colleagues, which described patients presenting to sleep clinic with insomnia symptoms driven by their sleep tracker data. And the patients are often going to become preoccupied with optimizing their sleep metrics, like their sleep score, their deep sleep percentage, or their total sleep time. And instead of focusing on how they actually feel after a night of sleep, they're going to be focusing on improving the numbers reported by the device. This can create sleep performance anxiety, which is similar to what we see in psychophysiological insomnia. Patients are going to be spending excessive time checking their sleep data, altering their bedtime behavior, or worrying that their sleep is poor despite feeling rested. And the key message to take home from this is that these consumer sleep trackers may improve awareness of sleep, but in some patients, they actually exacerbate insomnia symptoms through hypervigilance towards the sleep data. So this might be one of the only places where you want to tell a patient to take the device off and not use it. Future trends, so there will be some form of AI-powered sleep analysis integrated into these sleep devices. We'll have improved accuracy and validation, and then there will be further integration with personalized medicine. So in July 2025, the Children's Hospital of LA launches the first sleep registry in the country for children using Apple Watch, as well as a new data collection app called the Wise Hair. And the goal was to gather data for future research, like training machine algorithms from Apple to detect sleep disorders, provide crucial information to clinicians. And then wearables are going to be playing a role in tailored treatment plans, whereby data from the device is going to be helping optimize medications, therapies, lifestyle interventions for specific sleep disorders. So, in summary, these consumer sleep trackers are rapidly expanding. They're good for sleep detection, limited wake and stage accuracy, valuable for longitudinal behavioral monitoring, but they're not supposed to be replacing the clinical sleep studies. The PSG remains our diagnostic gold standard. But the future does look very bright with advancements in AI, integration with other health metrics, and then potential new treatments down the line. And yeah, thank you.
All right, fantastic. That was very comprehensive and informative on a very important topic. So I'm just going to go over a few things in the chat. I know we don't have much time, and I know some of you may need to get to state sleep, so please feel free to do that. Dr. Yagi brought up a good point about the specific population of sleep apnea. So I would definitely refer you to the comments and in the chat. And also, he attached a great article as well as a podcast about some of these issues. So that's very important. And then for those who didn't have a chance to get early when we first started, we initially, Dr. Mansi presented a case about a person who was really obsessed about their sleep data. So the question was, how did you handle the case presented at the beginning of the talk?
Yeah. So we actually ended up, explaining a lot to the patient, doing a lot of patient education and reassurance, first off, regarding his three negative sleep studies. But because there was some form of anxiety playing a role here, just in order to kind of close the loop, we did end up ordering another sleep study for him with a lot of education provided that it may also be negative. Just keep that in mind. And if and when it is negative, we do have to address the underlying cause of his sleep issues, which is his anxiety.
Right. And since that was my patient and we had Dr. Hutt talk about AHI, he was very informative about a 3% desaturation as
Uh,
opposed to 4%. And I promised him that we would score his study with a 3%. And he was worried about more snoring and other sleep-related sleep apnea symptoms. Plus also we're a sleep doctor, right? So we're going to do a sleep study most of the time. Okay. And then for a question came in for the patients with sleep state misperception, do any of the variables more closely match their subjective complaints? So I guess using these sleep trackers in patients with sleep state misperception or paradoxical insomnia, do any of the variables more closely match their subjective complaints?
Not necessarily. I think they're actually opposite, especially regarding the total sleep time. In patients who do have sleep stage misperception, their tracker is actually going to show them that they have been sleeping for much longer than they actually have. So there's a big discrepancy between what the patient subjectively feels and the objective data that we're getting from the sleep tracker. I don't necessarily think that there has been one variable that is actually aligned with what they have been subjectively thinking.
Yeah, that's important because also it's true for just standard actigraphy that we use in clinical practice. And so if I see an actigraphy that's perfect and the patient says they slept 2 hours, it's going to probably be paradoxical insomnia, and I'm going to need to do an in-lab sleep study. And then with the in-lab sleep study, I'm going to look at that post-sleep study questionnaire and see how long it took them how they think how long it took them to fall asleep and how much sleep that they have. And that's really important when you suspect paradoxical insomnia to look at that post-sleep study questionnaire that's given to the patient, and that will also clue you in on the diagnosis. Great. And then Dr. Bakhtiar says, great job. You crushed it. Fantastic. Thank you so much. So all good stuff. If anybody wants to unmute themselves and ask any additional questions, feel free to do that. And we are 2 minutes over, but I will ask just one question for those who stay. So we talked about this morning in sleep clinic where I find myself maybe a year ago, like just basically ignoring whatever sleep data the patient presents to me, to now I actually ask them if they have a sleep tracker and if they could provide that data, especially when they're excessively sleepy and I'm not sure what their sleep time is. So when do you find in your clinical practice it actually helpful to have patients' consumer sleep tracking data?
I would say in getting a better picture of what their total sleep time is. I also think it's nice for tracking heart rate. So in patients who are telling me that they're only going to be sleeping like 2 to 3 hours per night, and I know that's not true, I will often have them, pull up their data, whether it's on the app or it's on the device themselves, so we can go through and see what the tracker is actually picking up. Same thing goes if they're complaining about issues with like palpitations or sweating during sleep. It's always nice to see if the tracker is picking up on that too, just to allow for some further information. But those are the two big things, or the two big like scenarios in which I would ask them to pull up data for me. If they're going to be talking to me about the different stages of sleep that they were in, especially the issue regarding not getting enough deep sleep, I do tend to, provide more education on that and tell them it's not going to be accurate.
Great. Fantastic. Before we end, anyone have a last question or comment they want to share?
I have one. Has it at all been helpful in getting a picture of restless leg syndrome?
Ooh, that's great. I couldn't find anything when I was doing the initial literature review on patients specifically who have RLS. However, the Apple Watch data initially, when it was published, did talk about how the movement that the patient undergoes just from the RLS does affect the wrist motion that the watch is detecting. So it will likely flag more motion and possibly trigger whatever their movement threshold is, if you do have some form of an underlying RLS picture going on.
Yeah, and that's an important thing that, as you mentioned in your presentation, these sleep trackers, total sleep time is really the only thing you can trust. And that's in mostly patients that don't have an underlying sleep disorder. So by virtue of them coming to your sleep clinic, there's going to be a good chance that they have a sleep disorder. So again, that's an important thing to know, that like in sleep apnea and in restless legs and insomnia, there's very little data to show that these trackers are going to be very accurate. So that's an important caveat to that. So great. And then I know you don't have any disclosures. You're not getting paid by any of these companies. But do you have any preference on the type or model of tracker at this time?
Good question, Amy. Yeah, no, I would say if we just go off the data, yes, the Aura Ring is, I would say, most consistent with what a PSG is going to be showing. However, once again, when we look at the breakdown of sleep stage detection, it's not that great. And then the other thing I do want to keep in mind is regarding cost of the device. The Oura Ring is one of the most expensive devices out there. And then plus, after purchasing the device, you do have to have a monthly subscription service in order to actually appropriately use all the features that it has and to look at the data that it collects. And fun fact, you actually cannot deactivate your Oura Ring subscription. You either have to keep paying or you cancel, and you lose all of that data. So if I had to go off of what I would most prefer and what I would tell patients to get if they were really concerned, sure, the Oura Ring, but cost does play a role into this.
Yeah, that's a great point about the cost and equitability. So I think one of the things I would like to see the field move into is less on validation and more on patient-centered outcomes that are able to be demonstrated from the use of these sleep trackers. That's where there's a big hole in the literature. And so before you start speaking about equitability and that type of thing, does it even help you to have a sleep tracker? I think the answer is not known yet. So you can't really have an equitability conversation when we don't think it actually helps you yet. Once we prove that it can help you, then we have the equitability conversation, and hopefully the price can come down. And obviously the technology is getting better and better, so that's also playing a role. So, all right. Well, thank you so much, everyone. Enjoy the rest of your day. And thank you, Dr. Bhatt. Appreciate it.
Thank you.
Good
Thank you so
job.
much for having me. Take care.